Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Yeah. Good morning, everybody, by Mountain Time, Colorado. Good afternoon by England time. Good evening by Cairo time, Beirut time, and Mecca time. We are all over the world to introduce today our webinar regarding to emergency medicine section for the online POCUS fellowship. Let me send your greeting from Dr. Amr Al-Husseini, President of World Institute Academy for Critical Care and Emergency Medicine, Dr. Ashraf Al-Tayyar, Director of the Fellowship of POCUS, and me, Wissam Ibrahim, Academic Director for Emergency Medicine Fellowship. We have today our moderators and our great shiny speakers. For the moderator, we have Dr. Muhammad Boulad, Consultant of Emergency Medicine and Head of Emergency Medicine Department at New Mazloum Hospital, Lebanon. Dr. Dina Magdi, Consultant of Emergency Medicine, Lecturer of Emergency Medicine and Traumatology in one of the pioneer Egyptian University, Alexandria University, Egypt. And we have our great speakers, Dr. Grace Wanjiko, which will be presented by Dr. Dina Magdi. The floor is you, Dr. Dina. Dr. Dina is here. Okay. Let me introduce my colleague and my dear professor, Dr. Grace Wanjiko. Dr. Grace Wanjiko is Associate Professor of Emergency Medicine and Albert Brown University, graduated from Yale University School of Medicine, and got point of care ultrasound fellowship and research from Yale University for 2 years. She is one of the eminent speakers in the whole world, especially in middle and low income country, with tons of publication and point-of-care ultrasound maneuver, especially in Kenya, South Africa, and she was one of the first professor to come to Cairo in 2016 to teach us how point-of-care ultrasound work. Now the floor is you, Dr. Grace, and your beautiful lecture about obstetrics and gynecology. Let's go.
I thank you. Thank you so much, Dr. Wissam Ibrahim. It's a pleasure to be here. Thank you so much for your invitation. And if that's okay, I can go ahead and share my screen to start my presentation.
Okay, let's go.
I hope you can see that okay.
Yeah, we see it.
Okay, mine is going to be a short case series on OBGYN. And these cases come from our training program in Kenya. So currently we have a training program with the Emergency Medicine Kenya Foundation. And so these are cases that come from practitioners that are currently working in low resource settings in county hospitals in Kenya. And they are recent trainees of the program. So the first case is, these are going to be really short, just illustrative cases. They will not be exhaustive. The first one is a 22-year-old female coming in with lower abdominal pain. She said nausea, vomiting. She's been having nausea, vomiting in the morning for several days now. And she comes in hypotensive and she is tachycardic. She comes into the acute care setting in the emergency department. So our trainees send off the blood work, including the urine pregnancy test, but they do not wait for the pregnancy test to come back. They go ahead and do the point of care ultrasound. And this is a clip. Let's see. I hope this will play. Okay. Sorry. This is a representative clip of the sagittal view of the female pelvis, which right here, it shows the key landmark here, which is the bladder. We see the uterus here in its sagittal view. It has the pear shape. We see the endometrial stripe in there, and there's nothing within the endometrial stripe in this lady. But more concerning, we see a lot of hypoechoic material around the uterus. So that's the sagittal view. Then we go ahead and play the transverse view of the female pelvis. So the probe marker is now transverse with the probe marker facing the patient's right. We see the bladder here, which is your key landmark. We see a lot of free fluid here. And the uterus comes in posteriorly. We see the endometrial stripe within it, and there's no IUP, there's no intrauterine pregnancy. We just see a lot of debris and free fluid around the uterus. Okay, so in the same patient, the clinician went ahead and obtained the right upper quadrant view, or the EFAST view. And this is what they see. So there's a kidney here, that's a liver, and there's a stripe of free fluid in the Morrison's pouch. And that's the same case here. We see the tip, and there's free fluid here, kind of on the caudal tip of the kidney there. Okay, so we're gonna move ahead to the next case. This is a 23-year-old female. She comes in, she's fatigued, she is pale, she's been having vaginal bleeding, she is hypotensive and tachycardic. So once again, you examine this patient, send off the blood tests, send off the urine pregnancy test, but they go ahead and do the ultrasound anyway while they're resuscitating this patient because she is critically ill. And this is a representation of the ultrasound, the sagittal view of the female pelvis. Once again, we see the bladder is up here. This is a key landmark for us. We see the uterus in its pear shape, and we see all the way around it is free fluid. Same thing, this is the transverse view. Once again, this the uterus has the apple shape now, and we don't see anything within the uterus. We just see a lot of free fluid around it. The third case, 30-year-old female, lower abdominal pain. And these are real cases that were managed in these small county hospitals. This 30-year-old female Same thing, lower abdominal pain, her last menstrual period. She says she had a little bit of spotting last month. She does not think that she is pregnant. And once again, we see the bladder here. The uterus is going to come through. We see an endometrial stripe there. That's the uterus here in its sagittal view. We see a lot of free fluid around it. And this is a transverse view once again. The bladder comes in first. And then we just see a lot of debris and free fluid behind it. There is your uterus. There's an endometrial stripe. There's nothing within the endometrial stripe where a pregnancy would be. So clearly, these are all cases of female patients presenting in their first trimester. And we're going to talk about what are the goals of POCUS in the first trimester. All right. So the goal is to confirm whether there's an intrauterine pregnancy or not. And clearly, in these patients that we discussed, none of them did. We did not see any intrauterine pregnancy. If you see an intrauterine pregnancy, which I'm going to now henceforth call an IUP, if you see an IUP, then you want to establish the gestational age. And if you see a multiple gestation, then we should document that just because that woman needs very close follow-up. So the scanning technique for this, we use the curvilinear probe. I'm going to rush very quickly through these. The transverse view, that's what it would look like, just over this pubic symphysis with the probe marker facing the patient's right. And that's what it would look like. The bladder comes more anteriorly, and then more posteriorly, you see the uterus there. That's a sagittal view, with the bladder here juxtaposed with the uterus. Okay, and so this is what an IUP would look like. And I just wanted to document that when we're looking in the emergency setting to define an IUP, we want to see three things. We want to be able to see the gestational sac. We want to be able to see the yolk sac, and we want to see the fetal pole. So here we see the gestational sac. We see the yolk sac that looks like a Cheerio here, like the cereal that's called Cheerios. And then we see a fetal pole. And actually, if you look a little closer, within that fetal pole, we see a little bit of a fluttering. So if you see a fetal heart rate, it actually confirms that you have a live intrauterine pregnancy, which is what we really want to see in the first trimester in the emergency department. The other thing that we need to confirm when we're defining an IUP is that anytime you see something that looks like an IUP, so it has all the three features, we want to make sure that it looks like this picture, that there's a nice thick endometrium all the way around it. If it looks a little eccentric, it's off to the side, and you have anything less than 5 millimeter on the edge here of the endometrium, then that would be concerning. That could be concerning for a type of ectopic called the interstitial or corneal ectopic. So we really want to make sure that we have a nice thickness around it. And that thickness is usually defined as an endomyometrium mantle. We want it to be more than 5 millimeters from the edge of the myometrium to where the IUP begins. So then that's what an IUP would look like, and that's what we want to see. But as the case of the three cases that I presented to you, we did not see any definitive intrauterine pregnancy, so it was an ND-IUP. And anytime we see an ND-IUP, it could be three things. It could either be early pregnancy, it could either be ectopic pregnancy, or it could be a spontaneous abortion. In the patients that we had, there was a lot of free fluid around the uterus. So this raises the concern that it's not only an ectopic pregnancy, but it's a ruptured ectopic pregnancy, which then increases the rate of, this is an emergency situation that needs early and quick management. So an ectopic pregnancy is a specific kind of ND-IUP, a non-definitive IUP. You look inside the uterus, there's no IUP. There's a lot of free fluid in the pelvis. When the test comes back, and I always tell the people who work in the emergency department, send off the test, the beta HCG, either the blood test or the urine, but do not hesitate to do your ultrasound. Always ultrasound first, right? Because if someone is hypotensive and you're resuscitating them, and it is a woman of childbearing age, they have a ruptured ectopic until you prove it otherwise, right? So if you look with your ultrasound and they have free fluid and you're resuscitating them, this is someone that we would start to mobilize to start to make a plan for them to go to the operating room. The pregnancy test, sometimes in our settings, it can take some time. So I won't take too much time on this because we know this. This is just the different places where the ectopic will go. We always, discuss this case of a heterotropic pregnancy. It occurs when there's a simultaneous intrauterine and an ectopic pregnancy. This is a rare occurrence. And this is why I tell people in the emergency department, right? You're looking for that IUP. If you don't see it, it's likely, implanted somewhere else. The fact that someone could have an IUP and then have an ectopic implanted somewhere else, it's rare, right? 1 in 4,000 or up to 30,000 of spontaneous pregnancies will be a heterotopic. Unless the woman is going through reproductive technology, then your bets are off. Even if you see an IUP in a woman who's going through assisted reproductive technology, they could still have an ectopic. So if they're behaving like they have an ectopic pregnancy, they have free fluid where free fluid shouldn't be, even if you see an IUP, you should not be reassured. Okay, so the incidence of this globally, 1 to 2% of pregnancies end up with ectopic pregnancy. That's about 6.7 million cases in the world in 2019. So this is a lot of women that we are talking about. In low and middle income settings, you will find that, first trimester POCUS is one of the most critical skills to have, just because we have a lot of patients coming in with this. In the emergency department, the incidence is higher. We're just talking about all comers globally, right? But for young women of childbearing age who come into the emergency department, 15 to 20% of them who come in with abdominal pain or vaginal bleeding or hypotension. So that's up to 20%. About a fifth of all our young women coming into the emergency department will have this. And it is, sadly, the leading cause of pregnancy-related death in the first trimester. So this is something we just need to keep an eye on. And please let me know if I'm running out of time. There is a lot of disparities that are associated with this. I won't, but the highest mortality of this is born in low and middle income countries, right? Because we are the ones who are struggling so much with diagnostics. We don't have the diagnostics to be able to pick this up. But now we have ultrasound, right? So we want to be able to pick this up quickly. And once we pick them up, to be able to act on them. So to take these women to the operating theater, because the bulk of the mortality is located in our settings in low and middle income countries. Okay. So the clinical presentation in school, we learn about the abdominal pain or pelvic pain, amenorrhea, vaginal bleeding, but a lot of these women will present with very non-specific findings. They'll come in dizzy, nausea, vomiting, they'll come in hypotensive, they syncopize somewhere. So always use your ultrasound, always look, right? If they are ruptured, they will come in hypotensive, they'll come in with tachycardia and peritonitis. So while we're resuscitating them, waiting for your labs, I say it over and over again, POCUS first, always POCUS. So I think we went through this. If someone presents like this, they have a ruptured ectopic until you prove it otherwise. Okay. So utility of POCUS when it comes to the management of ruptured ectopic, there are studies that show that it has decreased the length of stay by an average of 70 minutes. It decreases the time to operative intervention by 90 minutes or more. It decreases the likelihood the patient will return with an ectopic. So it decreases the likelihood that a woman will be misdiagnosed, sent home, right? And then they come back with a ruptured ectopic. So what I'm trying to say is that when you look with your ultrasound and you see an IUP on POCUS rules out an ectopic pregnancy in a natural pregnancy, right? Unless someone has is undergoing reproductive technology. If someone is stable and you look with your ultrasound and you see that they have an IUP, or even if they don't have an IUP, but if they are stable, then they can go to the ultrasound department to get a comprehensive ultrasound. If they're unstable, then we're doing everything at the bedside. So another word that I wanted to say about beta HCG testing is that we've heard about this, the beta HCG discriminatory zone. So this is a serum HCG above which an ultrasound is expected to detect a viable IUP. So for you to see anything transabdominally, you are supposed to have, a HCG level of 6,000. At an HCG level of 1,500, if you do a transvaginal ultrasound, then you will see an IUP. That is the teaching, and that happens in a pregnancy that is normal, right? If you have a normally developing first trimester ultrasound, you measure an HCG, it's more than 6,000, you look through your abdomen with an ultrasound, you should be able to see an IUP. 1,500 value, you look transvaginally, you should be able to see an IUP. That is normal. That's what happens when the development is going on as it should. The problem is that an ectopic pregnancy is not a normal pregnancy. It's a failed pregnancy. And so you can have an ectopic that can present at any beta HCG level. You can have a woman coming in with a ruptured ectopic and you measure the beta HCG and it's 250, right? So all I'm saying is that do not let the beta HCG value distract you. So if it comes back and it's low, don't say, oh, this is just an early pregnancy. This is why I don't see an IUP, because the HCG is low. It could be that they have a failed IUP. It could be that they have an ectopic and that it's either ruptured or waiting to rupture. So does that make sense? So what to keep in mind is that an ectopic pregnancy is a failed IUP. And so the beta HCG level does not develop as a viable pregnancy would. So a low beta HCG does not always mean it's an early pregnancy. So always ultrasound first. The findings on your ultrasound will be more informative to you than the number itself. And obviously how the patient looks will be more informative to you. Okay, so the management, I won't go through this because, once you diagnose an ectopic pregnancy, you see a lot of free fluid. If someone is unstable, there's not going to be medical management for this. If someone is unstable, you're calling OBGYN and they're going to surgery, right? Unstable patients always require surgical management. But if someone has an ectopic that has not ruptured and they are stable, there are protocols for how to treat them with medications, methotrexate. So every region and every area has its own protocol. So all I would say is talk to your OBGYN specialist and come up with a plan for how to manage someone that has an ectopic that has not ruptured. So I won't go through that. This is just the last case because I know I'm running out of time. This 23-year-old female, she is pregnant. She's been confirmed before. She already had an ultrasound. She already had an IUP, but now she's coming in with heavy vaginal bleeding or cramping. And you look in, this is the transverse view. We can see the uterus here, but there's nothing in there. And once again, this is a sagittal view. We see the uterus there, and there's no longer an IUP. And this woman is bleeding heavily. So sadly, this is a case of a spontaneous abortion. Okay. Yeah, so once again, consult GYN. If a patient is unstable, they will have to go for dilatation and curettage. They'll have to go to surgery. I don't think I have any more time to continue with these cases, but all I'm trying to say is that we do have the ability. I think there is a pretty heavy burden, up to 20% of women with childbearing age coming into our emergency departments who could have an ectopic pregnancy and worse still could have a ruptured ectopic. And these cases came to us pretty quickly from rural Kenya after we had trained these providers. They went home, we asked them to send us cases, and most of the cases they send us are these. And so this is a pretty useful skill to have, one that we're going to emphasize. And all you have to do is put your probe over the pelvis. Is there an IUP? Is there no IUP? Is there free fluid? Is there no free fluid? And that in itself, as simple as that, makes a difference, big difference in how this woman is managed. So I hope that makes sense. Please ask me more questions, and thank you.
Thank you so much, dear Grace. And we are waiting for any questions guided by Dr. Dina Magdi. Do we have any question, Dr. Dina, in you and answer?
Good evening, Dr. Sam. Till now, no questions.
No questions. Okay. So I have a question to you, Grace.
Yes.
I know that Yeah, I know that most of people hearing us today, especially from low and middle income country where the emergency medicine is still a new specialty, they may find that what you are saying is a fairy tale because you know that most of countries has its own specialty. For example, OBY gyna dealing with emergency in OBY gyna. So first of all, I have a question to you, and I know the answer, but just for explanation. And after that, I have like a plan, if you are okay with me or not. My question to you, you are a purely emergency medicine physician, and you already practice that. And I know you are based now in US, and you already practice that in emergency medicine department because most of people who hear us think that you are OPY gyna professor or something. So could you emphasize that for me and all the people? That you are emergency medicine physician and you already practice that. That will make people more powerful and think highly for their next step.
Yes, so I practice emergency medicine. I trained in emergency medicine. I just happen to really love point of care ultrasound, and I work in, global emergency medicine. I work in settings that are low and middle income. But I will say it doesn't even matter, even if you're in the high income settings, first trimester obstetrics present to the emergency department. They come to the emergency department. They present acutely in the casualty, in the accident and emergency, depending, it doesn't matter what you call it in your country, because some of these and the bulk of these women will not know that they are pregnant. They have not done a pregnancy test at home. They are not sure that they are pregnant because some of them could have some spotting, So maybe you had some spotting last month and you thought that was a full period. They might have some bleeding in the first trimester. So a lot of them do not know they're pregnant. So they come to us, right? And as you saw that statistic, so we're talking about 1 to 2% of women globally, all comers, 1 to 2%. But people who come to the emergency department, if it is a woman of childbearing age and they have abdominal pain, they have vaginal bleeding, they are hypotensive, they syncopize somewhere, they have a ruptured ectopic, 20%, 15 to 20%. And so this first trimester belongs to the emergency department. We own that, right? The job to diagnose it and make sure that it is well managed is ours. Because
Yes.
second and third trimester, they already know they're pregnant. So they don't come to us. They go to OBGYN clinic. First trimester, they come to us.
Yeah.
So I hope
So
that makes sense.
it's like more than enough just to explain to our colleagues and friends about the magic tool of POCUS, of course, and the wide and generosity of emergency medicine. My plan or like my comment on that I know that by laws it is difficult in our countries to take it from first, but we can play it in another way, of course, with the hospital policy and rules and everything. For example, most of the trauma patient who in childbearing period come to us as a trauma patient, not as a pregnant. And as my colleague Chris said, sometimes this spotting is got unnoticed, and even we say that's like it died with its secret. We don't know why it died, but with magic tool of POCUS, we can start as for those traumatic females in childbearing period, we start to make our examination, systematic examination, and take the confidence of how to do the examination. And if we find anything, we can at first call our OB-GYN friends to learn from them more and more till we make a new generation which is completely dependent on diagnosis and how to reach diagnosis to make everything realistic and not just a fairy tale with a good instructor and a good lecture, but to build on that in the future. Thank you so much, Dr. Grace. Thank you, Dr. Dina. And now
Dr.
with Dr.
Wissam, we have a question.
Yes, go ahead.
Okay, Dr. Grace, there is a question for you. Do you use Doppler ultrasound in emergency to diagnose ovarian torsion, or you always need obstetrician or radiologist to diagnose?
So in this case, I like to keep my teaching very simple. And today, I think, my kind of I just was very focused on ectopic pregnancy just because of the burden of morbidity and mortality. I will say that the diagnosis of ovarian torsion, a lot of times for me, at least in my current practice, I usually need OBGYN or radiologists, because I don't want to complicate things for people in the emergency department. If you are concerned about ovarian torsion, a lot of times these patients will be stable enough that you can send them to a radiologist, that they can get Doppler studies, that you can call OBGYN. And so for me, I like to keep things very simple when we're talking in low and middle income countries, that if you do have a radiologist, and if you do have an OBGYN, that to make a consultation for this patient. And the key here is that they are stable enough to go to a radiology and get the Doppler studies. Of course, if you work in an area that you have no access to this, then you would have to get very specialized training. It goes a little bit above what we teach in the emergency department. You would have to get more training to be able to do this safely, to be able to make the right call, because I don't want people out there making a call, that is not, that is wrong. With point of care
Yes.
ultrasound, I like to keep it very simple to make sure that people are staying safe and making diagnosis that they are 100% sure about. I hope that makes sense.
Okay, thank
Okay.
you, Dr. Grace.
Thank you, Dr. Grace. Thank you, Dr. Dina. Now the floor is you, Dr. Muhammad Boulad, to introduce your guest, Dr. Haitham.
Hello, everybody. I hope you're hearing me.
Yeah, we hear you clearly.
It's my honor today to contribute with you to introduce Dr. Haitham, a friend of mine. He's an emergency consultant in King Fahd Hospital. He's the general manager of Sono School. He's a medical director of MedPro, and he's a well-professional international speaker and instructor. So, Dr. Haitham, the floor is yours.
Yes, thank you, Dr. Mohammed, for this nice introduction. And I want to thank Dr. Wissam, Dr. Grace, Dr. Dina, and all the participants. I hope you can listen to my voice very well. So our webinar today and my talk is about the use of POCUS in the cardiac arrest. Actually, we want to know why POCUS in cardiac arrest. What about the recent guidelines of the American Heart Association? How we can integrate the POCUS in the CPR? And what is the role of the POCUS in the reversible causes? What is the difference between the pulseless electrical activity and the pseudo-pulseless electrical activity? How we can differentiate between the asystole and fine VF? Okay. Let's start with the scenario. 40 years female attended to our department in a cardiac arrest. There is no palpable pulse. She has a history of progressive dyspnea. She was using oral contraceptive pills. When we started the CPR at the beginning, activated the code blue, and we started to use the ultrasound. What you can see in this subxiphoid view of the heart, you can see that there is some contractility in the heart. So what will you do? Will you continue the CPR or will you stop the CPR? And how you will use the POCUS in determining the reversible causes? This is our question. Okay, let's go to the AHA new guidelines and the ERC. They are recommending the use of POCUS for reversible causes if it doesn't delay the compression. This is the most important issue. So how we can use the POCUS effectively? We have to work in a team approach. So we have to do the CPR in a high quality. You are now the team leader. You will ask the operator dependent to be prepared for the ultrasound, apply gel, and he will be ready. Once you stop in the 2 minutes to reassess the pulse and check the rhythm, now he will put his probe in different zones and we will demonstrate these zones now for less than 10 seconds. To evaluate quickly, he can record, take a clip, and while you are going in the next cycle of CPR, he will start, and you will start to evaluate the clip you take from the ultrasound, and don't interrupt the CPR. So this is how we can integrate the POCUS with the team approach in a cardiac arrest. The team is working for 2 minutes, and now you are ready with your probe. At the first stop, in the first 10 seconds, you will put your probe in the subxiphoid area to check the subxiphoid view of the heart and the IVC. And in the next stop, in the 10 seconds, you can put in the apical 4-chamber view. After that, in the next stop, in the next 10 seconds, you can check for the lung in mid-clavicular line for both lung. After that, for the costophrenic angle, and then you can go to the femoral vein and femoral artery. What you are looking for? You are looking for the heart. You want to see if there is some contractility or not, if there is fine VF or not, and you want to reach to the reversible causes of the cardiac arrest. Okay, let's go back to our patient. Actually, this patient was cardiac arrest, and the pulse, her initial pulsation was pulseless electrical activity, and we started to look for the reversible causes from the history, from the ultrasound. We could find that the right ventricle is very huge, and she was in a history of the oral contraceptive pills, and this patient was a case of pulmonary embolism. So we started the bolus of thrombolysis, and then the patient came to ROSC and admitted to the ICU. Okay. So let's revise our algorithm for the cardiac arrest. You check the rhythm and you find either the rhythm is shockable or non-shockable. If non-shockable, it is either asystole or it is pulseless electrical activity. So when you use the ultrasound in the subxiphoid view, you can actually know if it is a true pulseless electrical activity or it is a pseudo-pulseless electrical activity. So what is the pseudo-pulseless electrical activity? Pseudo-pulseless electrical activity, actually it is BEA, but you can find with the ultrasound some cardiac contractility. If you look to this view, as we discussed the case of the pulmonary embolism, now this is a pseudo-pulseless electrical activity. So you can see some cardiac contractility and cardiac motion. We can call it pulseless with a rhythm with echocardiac motion. But on the other side, this is the true pulseless electrical activity where the heart is standstill and there is no cardiac motion, no cardiac contractility. So what is the value of the pseudo pulseless electrical activity? Actually, patient with the pseudo pulseless electrical activity has a good prognosis, and you have to work aggressive to find the reversible cause and treat as soon as possible. And after ROSC, you have to act with this case as a profound shock, and you can use the vasopressors to save the life of this patient. So the patient of pseudo-pulseless electrical activity is a case between the hypotension and a true pulseless electrical activity, where there is a cardiac motion and you can find a POCUS pulsation, but you can't feel a true pulsation in your patient. So it's very important to know the prognosis and to know when to terminate and to search and look for the reversible causes. Okay, let's go to the second scenario. This is a cardiac patient, non-cardiac patient with ischemic heart disease, diabetic, and hypertensive. He came from a remote area after severe and typical chest pain. When you attach the monitor, the patient was asystole and there is no pulsation. You started the CPR, started the algorithm, activated the code blue, and you started to use the ultrasound. When you started to use the ultrasound, what did you find here? While using the ultrasound, you can find in the ultrasound a fine VF. The fine VF you can notice very clear in the ultrasound. Let's see the comparison between the asystole and the fine VF in the ultrasound. Okay, so now if you find that the patient is fine VF, you will change the protocol from non-shockable rhythm to a shockable rhythm, and this has a better diagnosis and better prognosis for your patient. So now you can see that the ECHO and the POCUS started to change the algorithm of the cardiac arrest. Another issue which is very important, that the POCUS help us to define the cause of the peri-arrest patient and for the reversible causes of the cardiac arrest. So if the patient, for example, is hypovolemic, you can see the patient in a peri-arrest state. He has a hyperdynamic heart. You can see in the subxiphoid view, and you can see that the ventricle the heart is nearly empty, and the IVC is collapsible and kissing sign of the IVC. So if the patient has hypovolemia, maybe due to hemorrhage, dehydration, septic shock, if he is arrested in the ultrasound, you will find that the ventricles is obliterated and the inferior vena cava is less than 2 centimeters. In the peri-arrest state, you will find that the heart is hyperdynamic, obliteration of the ventricle, kissing sign of the inferior vena cava, and the IVC collapse more than 50% during inspiration. If your patient is a cardiac and you are suspecting MI and the patient in the peri-arrest state, you can notice the global hypokinesia of the heart. You may see in your patient severe mitral valve regurg, or you can see wall rupture of the ventricle. You see the plethoric and the congested IVC of the patient, which is not collapsed by the inspiration, collapsibility less than 50%. And if you check the lung, you will see the B lines, which means that there is a lung congestion, and you may see also a pleural effusion. So if the cause of arrest is cardiogenic due to ischemic heart disease or cardiomyopathy, you can see the hypokinesia or akinesia or severe mitral regurg or wall motion abnormality or free wall rupture. If you are suspecting tension pneumothorax as a cause of the cardiac arrest, so in the peri-arrest patient, you will see absent pleural sliding. You can notice the lung point, which is very specific in the pneumothorax. In the M mode, you will see the barcode sign, and you will see also that there is absent lung pulsation. So it is very important in diagnosing the tension pneumothorax. If the patient is arrested during artificial ventilation, you will see absent lung sliding. In the peri-arrest sign, you will see the absent lung sliding, absent B line, absent pulmonary pulsation, and you will also see the lung point. If your patient has a cardiac tamponading, what will you see? You will see anechoic collection around the heart in the subxiphoid view. And what is the sign of tamponading in the peri-arrest patient? The sign of tamponading is systolic atrial collapse and early and diastolic right ventricular collapse, which is called the trampoline sign because it is like the trampoline. And this is a sign of cardiac tamponading. And this patient in the peri-arrest state, you have to do the pericardiocentesis as early as possible. And of course, you will find that the IVC in this patient will be plethoric as a cause of obstructive shock. So if your patient in a peri-arrest state It may be pericardial effusion, plethoric IVC, trampoline sign, systolic collapse of the right atrium, and diastolic collapse of the right ventricle. If your patient arrested, you will find pericardial effusion around the heart and plethoric IVC. The cause of tamponading may be type A aortic dissection, may be due to cancer, may be due to renal failure and uremia. Other cause and one of the reversible causes in the cardiac arrest is the pulmonary embolism. The pulmonary embolism in the peri-arrest state, you can find in this picture in the apical four-chamber view that the right ventricle of the heart is dilated, enlarged, and it is more than the size of the left ventricle. Usually, the size of the right ventricle is 2/3 the size of the left ventricle. What else you can see? You can see the hyperkinesia of the apex, and this is called the McConnell sign. And you can also see the reversible movement of the septum. Let's look at the short axis of the heart, where you can see that the right ventricle is huge, dilated, pushing the septum toward the left ventricle, and the left ventricle, you can see the D shape of pulmonary embolism. If you check the IVC in your patient, you will find that the patient has a plethoric congested IVC. So this is the signs of pulmonary embolism in the peri-arrest patient. You may find also pulmonary hypertension, hyperdynamic left ventricle. You may find deep venous thrombosis, paradoxical septal systolic movement, septal flattening in diastole, McConnell sign, and the D sign of left ventricle. If the patient is arrested, you can see the D sign of the left ventricle, the right ventricular dilatation. You may see a thrombus inside in the right heart and in the right side of the heart, and you may see a deep venous thrombosis. So the pulmonary embolism is one of the reversible causes in cardiac arrest in your patient. What else you can see during the POCUS of the cardiac arrest? Please check the femoral vein and the femoral artery. In the femoral vein, you can see a thrombus, which may be the cause of the pulmonary embolism. And also, you can check the return of spontaneous circulation from the pulsation of the femoral artery in your patient. What else about the use of the POCUS in the cardiac arrest? We can use the POCUS in the intervention. If you want to do a pericardiocentesis guided by ultrasound, if you want to insert a central line guided by ultrasound, so all of these procedures must be guided by the ultrasound. So remember the use of the ultrasound in differentiating between the reversible causes and the management of your patient. Remember to use the POCUS in organized manner and don't interrupt the compressions. To summarize our webinar, and after that we will receive any question from your side. We know the importance now of the POCUS in the cardiac arrest and the recent guidelines supporting using the POCUS, but without interrupting the compression. And we can now integrate the POCUS in CPR, working as a team without interrupting the compression to find the reversible causes like hypovolemia, pulmonary embolism, tension pneumothorax, and cardiac tamponading. And we also can know the difference between the pulseless electrical activity, the true pulseless electrical activity, and the pseudo pulseless electrical activity, which has some cardiac motion and has a good prognosis. And we also can differentiate between asystole and find VF to change the algorithm from the compression medication to shockable management of your cardiac arrest. Thank you. And if there is any question, I'd be happy to listen to your questions. Thank you.
Dr. Haitham, there are two questions here. I will start with the first one. The question is, in pseudo PEA, would you feel the apical pulsation, yes or not, or the carotid pulse?
Yes, in the pseudo BEA, actually, you don't feel the pulsation, but this is called the POCUS pulsation that you can see with the ultrasound. There is some contractility. So in this case, you have to look for the reversible causes using the ultrasound because it has a good prognosis. It's like a case of profound shock. Once you regain the pulsation, you can use as soon as possible the vasopressors.
There's another question. Can POCUS confirm the effectiveness of chest compression?
For the effectiveness of the chest compression, actually, you can't put the probe while doing the compression because this will interrupt the compression. And if you put the probe during the compression, actually, you will not see anything in the sub-xiphoid view. So actually, there is no study about using the ultrasound or the POCUS during the compression.
Thank you, Dr. Haitham. Thank you very much.
Thank you very much. Thank you.
Yeah, I just have a question to you, Dr. Haitham. As a general manager of Sono School and like a game changer in the process of POCUS education. So, do you think that like applicability of POCUS in general, in cardiac arrest in particular, and POCUS in general, help many people? So, of course, you have statistics and you have your own data about how many countries you entered, how many trainee get trained under the umbrella of Sono School, which you are one of your, you are one of the founder of this Sono School. So, do you think it's the science is already broadcasted to many people? Of course, we hope that's like many and many, but for now, that broadcasted to adequate amount of people, and how many countries you entered, even online or on site?
Yes, thank you, Dr. Wissam. Actually, I am a member of a great team, and you are a great, one of the founders and of the scientific committee. Also, Dr. Grace, also Dr. Dina doing a great job in Egypt, Dr. Muhammad in Lebanon, and all our colleagues. I don't want to forget anyone. Actually, POCUS, we are working in more than 12 countries, either in the MENA region, either in Africa, in UK, in Turkey, in India. Actually, point of care is a game changer. I am asking myself, when I am assessing my patient with a POCUS now, how could I manage my patient in the past without the ultrasound? Because actually, it is very, very important. And in the emergency department, you have a lot of debates between different specialties. For example, a patient of dyspnea, you have a debate between the pulmonology and the cardiologist. By using the ultrasound in 5 to 10 minutes, you can take a decision. This is a cardiac patient. For example, this is cardiogenic pulmonary edema. This is a non-cardiogenic pulmonary edema. The chest pain is due to aortic dissection or wall motion abnormality. So actually, it is a very important tool and a magic tool in the hand of the emergency physician, also in saving the life, also in doing safe intervention. Actually, I can notice the difference in the emergency physician who are using the ultrasound, and the emergency physician, he didn't use it till now. So actually, my advice to myself and all my colleague. It's a life-saving tool. It is not optional that you learn POCUS or not. Now, in the MENA region, we have trained more than 7,000 candidates and generated more than 500 instructors, and we are spreading all together this knowledge to save the patient life.
Thank you for your generous answer and your the help you introduced to many people and many colleagues. Now back to Dr. Mohammed Poulad for more question to Dr. Haitham. Could you check the Q&A section,
Yes,
please?
of course. The question is, how feasible is it to do POCUS in a busy, crowded CPR?
Yes, actually, you have to select your patient and you have to use the POCUS for the unstable patient because actually it will save a lot of time and a lot of unneeded investigation. I can give you, for example, if you are suspecting that the patient is a pulmonary embolism and the patient is unstable, what will you do? You can send your patient to the CT pulmonary angio and the patient is deteriorating. You need to take a decision now to give thrombolysis or not. So actually, it is not a choice, especially in the rapidly deteriorating patient. And if you are well trained in the POCUS ultrasound, believe me, it will not take more than 10 minutes to go through most of the body, through the heart, the lung, the IVC, the abdomen, and for the shocked patient, actually, it is a very important rule in non-traumatic shocked patient with different protocols like rush protocols and other protocols. Yes.
There is a really interesting question here. How to differentiate between ventricular fibrillation and pseudo PEA on POCUS?
Yes, actually, in POCUS, you will depend on the eyeballing. The fibrillation movement is different from a contractility. Actually, we differentiate this by the eyeballing, and also if Dr. Wissam can give us another guide in this question.
Okay. So for pulseless electrical activity, it's appear as a ECG, it's appear different from like frank VF. So if you still in doubt between VF to shock or just pulseless activity, continue CPR. Some publication proves that this CPR changed the fine VF to coarse VF, which is good responsible to the shockable rhythm. So if you still in doubt, deal it as a usual CPR. Once you did CPR, this fine VF, change it into coarse VF. This coarse VF is better and responsible to shocking, electrical shocking than the fine one. So it is a matter of experience, matter of eyeballing, as Dr. Haitham said, and a matter of cost-benefit evaluation with rapid decision.
Can we use norepinephrine with pseudo PEA if we suspect shock?
With the pseudo PEA, okay, this is rhythm is non-shockable rhythm. So you are continuing the CPR and the epinephrine. There is some studies about using the vasopressin, but actually not in the guidelines. So in the guidelines, continue CPR, use the epinephrine because it is non-shockable rhythm, search for the reversible causes because this has a good prognosis. And once you get a ROSC, start the vasopressor for your patient as a profound shock.
There's a question here. Is there any role of observing flow in the femoral artery during chest compression?
During chest compression, there is no rule in observing the flow, but you can use the ultrasound to detect the risk because you are away from the area of the compression and just put the probe over the femoral artery and vein. If the femoral pulsation start to be seen in the POCUS, this could be confirmed by the true pulsation of your patient.
Just one point to explain here. There is a very recent published paper and also mentioned of one of the Maryland University perils, but it is just for like emphasize the concept, not to get in confusion with the previous lecture. There is something called now we are talking about pseudopeia. Pseudopeia. The true peia is already we know that there is no heart activity. For the pseudopeia, there is no pulsation, there is no palpable pulsation, plus there is some sort of cardiac activity. Now they are got deep dive in this subject and they divide the pseudopeia till perfusional pseudopeia and non-perfusional pseudopeia. What does it mean? Both of them, there is no pulse. Both of them have cardiac activity. But what if I put end CO2 measure or I put intra-arterial device to measure the blood? If the blood pressure, the mean blood pressure, mean arterial blood pressure is below 50, it is non-perfusable. So if the mean arterial blood pressure is below 50, that means there is no actual blood going to brain or vital organ. So for non-perfusable pseudopeia, start CPR. Because in this condition, even there is a minute pressure inside the artery, but it's not adequate to vitalize the organ. The other division is perfusable pseudopeia. That's why when you put intra-arterial, I said intra-arterial, not from outside. It's like intra-arterial device. Above 60 or 50, this means that there is some hope of getting perfusional to the organ, and it is a controversy to continue CPR or just look for the 5Es and 5H to reversible contagion. So it is a very big and very huge subject. Not we don't wanna to go a lot of confusion. So for this lecture, just divided into either peia or pseudopeia. Peia mean no pulse, no heart. Pseudopeia may no pulse, but some cardiac activity. That's why the controversy come from. But before POCUS, we are totally blinded to have all this division. That's why this is a very new and very unique division. Before POCUS, we couldn't even detect. So once you are in doubt, go to CPR, no questions. Just go to the ALS, which is a large and meta-analytic study with all the proven. Once you are in doubt, go to CPR. Hope this answer all the confused questions.
Thank you
Okay.
very much. I think that there are no questions more. So I think we're done. Thank you.
Thank you. Okay, now go back to Dr. Adina Magdi. I think we have some question for Dr. Grace, I think from 1 to 5. If you could go to the QA and ask Dr. Grace if he's still with us.
No question, Dr. Wissam, Dr. Grace.
I
Only one
think there is some.
question.
Are you sure? Because I think there is some questions come after or.
No.
I think I saw some questions. There's someone who wanted a clarification on how to look for free fluid in the transabdominal view.
Yeah, that's what I mean. Yeah.
I can
Okay.
review it quickly if we have some time. I may have maybe gone too quickly through. Let me
Okay,
try and
just-
share my slides again. Ooh, 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 okay. Oh, sorry. Okay. Slideshow. One slide. So just someone who was asking about technique using the curvilinear probe. So the probe goes just above the pubic symphysis, as you see this gentleman here. Wear gloves, obviously he's not, but so this is a probe. This is a transverse view. The probe marker is facing the patient's right. So in emergency medicine, the transverse view, the probe marker faces the right side of the patient at all times, and you're just above the pubic symphysis. And then once you get there, then you kind of fan through the entire area to interrogate it. And this is what the image would look like. So they're fanning through. If the patient's bladder is full, a lot of times it comes up anteriorly here. So we can see the bladder, and you really want to be able to trace out the bladder to make sure that the fluid you see there is well contained within a bag. Because the pelvis is not a big space, it's kind of a limited space. Sometimes free fluid in the pelvis can look as if it is contained, but you really want to make sure that you see the walls of the bladder and you see it all the way through. That's why fanning is important. You fan all the way until the bladder disappears in one direction, and you fan all the way until it disappears in the other direction. Make sure that fluid is nice and contained. The bladder is a key landmark for us in the pelvis, so you really want to make sure you see it. That's why women, when we're doing this, we want them to feel their bladder. Obviously, in the emergency setting, they may not have had time to feel it, but that's a key landmark for you. And then posteriorly to that, we see the uterus coming through here. So this posteriorly here, we see the uterus. And the free fluid would be all the way around the uterus here, all the way kind of where I'm pointing. That's where all the free fluid would be. And then moving on to the sagittal view, same probe, but now the marker is facing the patient's head. We're still above the pubic symphysis. And then you're going to be fanning towards the right and towards the left until the bladder disappears in both directions. So this is what it looks like. Once again, the bladder is a key landmark for us. We see it here. And this juxtaposition between the bladder and the uterus is also very important. In this sagittal view, you see the uterus here right next to the bladder. It's juxtaposed to it. You really want to see that to make sure that you're looking at the right thing. So then we see the uterus here. We see the cervix in this area here, and you see the vaginal stripe coming through there. So that's what a normal female pelvis looks like on a sagittal view. Sorry, I don't know if yeah. So I hope that makes sense. Let me just see if I have more pictures of what free fluid in the sagittal view would look like this. So you see the bladder here. Once again, it's your key landmark for you. But instead of it being juxtaposed with the uterus the way we saw before, the juxtaposition is gone because there's just a lot of free fluid all the way around. So this is a sagittal view. The endometrial stripe here, we don't see the vaginal strip going well, but this is what free fluid on the sagittal view would look like. And then on the transverse view, we see the bladder. This is the bladder anteriorly here. This is all free fluid. And as you can see, it's not nicely contained in a nice box. And I should have fanned all the way until the bladder disappears. But then you see a lot of debris there. And then the uterus is deep to that. And there's an endometrial stripe within it. So it can look a little confusing, but here we see the uterus a bit more clearly. We see the bladder coming through. It's nicely contained within a thick wall, but all of this is free fluid. Sorry. I don't know if there's any more questions.
I think that's
Doctor,
it.
Doctor,
there is one more question to Dr. Grace.
Go ahead, Dr. Adina.
Is Doppler ultrasound of the ophthalmic vessels and optic nerve sheath routinely used in patients with hypertensive disorder of pregnancy?
Sorry, do you mind repeating that? Like using an ultrasound looking at the eyes.
Doppler ultrasound of ophthalmic vessels and optic nerve sheath routinely used in patients with hypertensive disorder of pregnancy.
I think it's a good idea to do it if, once again, if you've been trained on it. I did not, my lecture today was not on that. But I think that if it is within your protocol, if you do use it in your institution and you've been trained on it, there's no contraindication for using it on a patient who's pregnant. But once again, it's all about the training and making sure that you're doing the right thing, because a pregnant woman is just, like any other patient. They can have hypertension, they can have any other disorders. And so, why not? It just would have to be, we would need a session and, make sure that you know what you're doing and that you've been appropriately trained on it. Then go ahead and do it. Absolutely.
Thank you, Dr. Grace. No more
Yeah.
questions.
Thank you, Dr. Dina. Now to sum up everything, this webinars come as a part of announcement to our online POCUS fellowship, which is start as 24 hours generalized section. And from the second week of January, next January 2026, we will start our specialized part as emergency medicine section, with many lectures regarding to obstetric and gynae, musculoskeletal, optic nerve, shoulder dislocation, dyspnea, heart, and everything related to ultrasound with point of care ultrasound in the fellowship. Thank you so much to our great speakers, Dr. Grace Wanjiku, Associate Professor of Emergency Medicine, Albert Brown, USA, Dr. Haitham Khalifa, Consultant of Emergency Medicine, Fahd Hospital, and General Manager of Son School and the Medical Director of MedPro. Many thanks to Dr. Muhammad Boulad, Consultant of Emergency Medicine and Head of Emergency Medicine Department, Hospital of New Mazloum, Lebanon, and Dr. Dina Magdi, Consultant of Emergency Medicine, lecturer of one of the pioneer universities in Egypt in emergency medicine, Alexandria University. And thank you, Wissam Ibrahim, and hope to see you again and again in many other webinars. Thank you so much.
Thank you.
Thank you,
Have a
Doctor.
good one.
Thank
Thank you
you.
very much. Bye bye.
Salam alaikum.
Alaikum salam.
Salam alaikum.